Connecting with your community during a crisis. As hospitals and healthcare systems ramp up resources to focus on helping waves of patients stricken by COVID-19, how can they rely on community partnerships to serve those most in need in the midst of a global pandemic? Today we'll hear about one medical center's community strategy to maintain quality healthcare in these critical times. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. In this conversation, Darren Henson, AHA's director at the Institute for Diversity and Health Equity, explores how, despite the COVID-19 outbreak, Loyola University Medical Center, serving the Chicago area, remains committed to its partnership with a community-driven, multi-sector coalition. It's a combined effort promoting community health and health equity to support diverse and vulnerable communities. Professor Lena Hatchett from Loyola's Stritch School of Medicine shares how the relationship between the medical center's physicians and clinical staff with Proviso Health Partners ensures ongoing patient needs. This conversation highlights how leading practices in health equity can continue even amidst a pandemic.
Thanks, Tom. Welcome to a conversation about health equity, diversity, and inclusion. Today, I'm delighted to be joined by Professor Lena Hatchett from the Stritch School of Medicine at Loyola University, Chicago. Lena, thanks so much for taking your time for this important conversation.
Thank you. It's a pleasure to be here.
Lena, this is clearly an unprecedented era for all aspects of healthcare. As we move through this pandemic, can you tell us about Loyola Medical Center's relationship with Proviso Partners for Health and how it supports the health and well-being in your community?
Yeah. This time in response to COVID and addressing the social influences of health, there's no better time to have a relationship between the healthcare system and a community-driven multi-sector coalition like Proviso Partners for Health. The actual coalition and the relationship between the health system grew over time, over many, many years of faculty, students, staff, and community residents working to solve problems together. And over the years, the coalition has grown and expanded in its ability to mobilize for well-being. So I sit in the Niswanger Institute for Bioethics working on public health ethics, and my work partners with community residents who live in Maywood and Proviso, and we design the work together. We determine what grants, what initiatives to go after, and how to implement and evaluate that work. And there are other faculty like me at Loyola working in deep and close partnership with community residents.
Tell us about those community residents, so specifically the populations that are served by Proviso Partners for Health. And what are you seeing in terms of their experience during this pandemic?
It's really important to identify the community. And for us at Proviso Partners for Health, we are focused on working with African American low-income communities that are experiencing all the faces of structural racism. This community that's African American and low income are closed off from opportunity in housing, food security, transportation, employment opportunities, and opportunities to advance in employment when there are jobs available, and educational opportunities. And what's critically important to understand right now is these challenges from housing to education and lack of access to food has been a challenge way before COVID. And so when the pandemic hit, it spiraled so many more of us into an early crisis. The lack of jobs, the lack of income, and the lack of access to reliable food sources. Now in response to COVID, the entire community is relying on food pantries, delivery services, and volunteer operations to have reliable access to food.
Lena, are there other racial or ethnic groups in the community there that you serve?
We are predominantly African American. We have a large growing Latinx community, And then we have an immigrant community. And the income level in our neighborhood is low. So that describes the Maywood community. And then the surrounding communities that are struggling, they're African American also, and they may have slightly higher income levels. But our residents struggle with poor quality employment. So you may have a job, but it's not sustainable. You may be the first hired and the first fired in response to COVID. You may not have good benefits in those low-paying jobs. There are many workforce development programs in and around Chicago. And one of the gaps in that work is there are many organizations getting people into the workforce, but few are working on the sustainability of employment to career advancement and to actually be working within one's calling. And if we can, hospitals can play a role on career pathways for low-income communities, it would be a huge benefit, because just getting into employment doesn't necessarily create the pathway to sustain that employment, particularly in a crisis like COVID.
Has Proviso been able to help amplify or echo or translate the public health message to the people that you serve there?
So our coalition, we like to think that the language is definitely translated, but the culture of our community is also translated in the communication. So it means I'm going to hear this from a trusted community leader, and then I will feel safe and confident with that information. There's layers to misinformation around COVID, and it's who you're hearing the information from. Is that a trusted source?
Right.
The governor and the mayor are doing a really good job with the daily briefings. Like you and I probably are following up, and we can go on the internet, we hear something and we can fact check it or get more deeper information. But some of our low income people, if they're just relying on Channel 9, it's not going to be comprehensive information about social distancing. They don't have the time. They're struggling with the kids, the stress of all of this. So they may just listen to Channel 9 News that pops some 30-second blip of information. And so they don't have a full understanding of what's being said.
Wow.
Some of the messaging around COVID that's been on the daily briefings in the news wasn't necessarily tailored to low-income communities. Some of it was at a college or an expert level that would be hard to translate, or that messaging could mean something else for community residents. So some people understood, okay, social distancing and staying at home, but they questioned, did that include going to church or not? Church in our community could be a place where you get support for a crisis. So people had to make decisions about was going to church safe or not. And we've been able to at least understand some of those challenges and try to address them when we hear about them. And again, spreading through trusted networks and by word of mouth. People, community leaders who already had relationship with residents are spreading the accurate information. But it's an ongoing real challenge. I think you all heard some of the earlier myths when we were first responding to COVID. There was misinformation that said that African Americans were not at risk for COVID, and that has unfortunately spread to some people, and now we know that over 70% of the cases in Chicago are with African Americans.
So, Lena, Illinois' stay-at-home public health orders have upended normal operations, I would imagine, for many of these programs, like food distribution and wellness checks. Tell us a little bit about how operations shifted for Proviso.
So, thankfully, because we're a community-driven coalition, we were able to mobilize in less than a week to go from a clinic-based distribution where residents would come by and pick up the food and get nutrition education. We were able to know where people in need were and understand the importance of food access at this time. We received donations, and we were able to do a drive-through food pickup and delivery service with students, dietetic interns, and community residents volunteer, dropping off food delivery to families that need it and not putting themselves or the residents at risk. This is a no-touch delivery service. And because of the coalition knowing each other and knowing the needs, we were able to shift to emergency food distribution in less than a week. But it took a lot of thinking about how to do this following the stay-at-home guidelines, and many communities are trying to transition. We've been able to share our approach with other partners so they can mobilize too.
Wow. How did this community organization communicate with the wider community?
Communication is another key challenge African American low-income communities have. We don't have a regular newspaper, and getting the same message to all of the people in the right way is a real challenge. And when you ask people and survey them how they want to get information, word of mouth is still used. So there's just informal chains of communication. One key person spreads it through their networks. We have listservs, we have Facebook, and we have an e-newsletter that's run by a talented young man, Michael Romaine. And people use the trusted networks of information to hear about what's needed. And our system was upended by COVID. We worked very hard on the food distribution, and we're going to focus more on the public health message by partnering with Cook County Department of Public Health. This has been really difficult because, as you know, the information has been changing day to day. So it wasn't clear. We all knew stay at home, but what would the specifics? Should we wear masks? We knew wash hands and stay home, but some of the other messaging is coming out now, and we're hoping to get those messages out.
And tell us a little bit about how you have kept your volunteers safe. So you mentioned volunteers and students and some of the dietary students and or staff. How are they being kept safe as they go out to make these home deliveries?
So we've been very, very strategic about our work. We don't want to put anyone at risk. The vulnerable patients and families receiving food, or any of our resident volunteers, our students, or the dietetic interns. So we studied the CDC guidelines and the World Health Organization guidelines in our planning meetings. So each day we had briefings to understand what was appropriate and how we could do it. And then partnerships with public health leaders, we tapped into them to verify that we were doing the best we could. And then so being up to date, having these daily briefings. So from one day to the next, the guidelines changed. As you know, initially the guidelines were that we did not need masks. And then after a week, the guidelines were that we did need masks. So people are making masks at home. And in fact, one of the advocates who leads this whole initiative, her name is Mary Mora, and she's a registered dietitian and a certified diabetes educator and a native resident of Proviso. She's making masks at home on her sewing machine. So the two-part strategy of being safe, making sure we have the most up-to-date national guidelines, verifying that with our local public health department, and then implementing those changes day by day as needed. So for our delivery, just like Amazon, the food can be delivered and dropped off, and there needs to be no contact between our volunteers and the family who are receiving the food.
Wow, that sounds terrific. You really are putting in best practices into place. In leading practices like this one, we can see gains can be made towards health equity when both partners know each other well and have strong commitments to each other. Many of our listeners work in hospitals. Tell us how hospital and clinical leaders help champion the success of this partnership for health equity.
With this food distribution program, it started in one small clinic 1 day a week. And because of its success and the structure of mobilizing with the residents, asking them what they need, how do they need the food delivered, what food they wanted in their bags, we were able to spread from a clinic to a park district to schools, and now I'm mobilizing for emergency food distribution. To have that success and those relationships work effectively takes physician and staff champions like Mary Moore or Dr. Kimmy Sue, who runs the family medicine clinic at Loyola. These individuals are champions for improving health equity. So their own passion and their own experience kind of led this work. When we talked to Dr. Kimmy Sue initially about food distribution work, she was on board and helped to make the rest of the staff and provided aware of the possibility. Sometimes that's what it takes, one person to be a champion and an advocate for systems change. And she worked inside the clinic to help us, and Mary Moore worked outside with community to bring the two opportunities together for a successful program. We've spread and scaled this operation in countless ways because of these individual advocates who need and want change to happen. Dr. Kimmy Sue struggles every day with patients who are diabetic, seeing them come in to the clinic needing care, needing treatment, and knowing that they're food insecure. That is deeply distressing place to sit, to know that the patient needs food and we don't have a way of getting it to them regularly on a continuous basis. Knowing that they need that can help control their diabetes. And our program and our partnership is able to provide that and reduce the stress on our providers and our health staff. And sometimes it just takes one champion. So for those listeners struggling with addressing the social influences of health, you might look around and think, who is a champion to lead this work? Who's got the passion to work towards systems change? And when you find that person, they may be already working on initiatives that you can fund or support or leverage resources to advance that work, or they might have ideas that can be launched with a team. And that's how we've started, and that's how we've been able to sustain in terms of long-term success.
You mentioned, Lena, that some of the physicians themselves had experienced distress of knowing what the patient might need, which is access to healthy food, but maybe not having the right structure to help the patient access that. And it sounds like this program provided a way for them to do that by writing a prescription for food, right?
Yes. So they knew which patients needed food access. They have long-term relationships, trusting relationships with their patients, and this was such a challenge that patients did not have access to food. These physicians knew that the community didn't have a full-scale grocery store and no grocery store over the years. But our partnership, which includes growers, we have our own urban farm where we're growing food, and we're partnering with an agriculture coalition called Windy City Harvest, and they grow food and train residents to be farmers. Our students, our volunteers, and our delivery system was a partnership and an opportunity to leverage those resources to get food to the patients who need it most. So when hospitals partner with community organizations, they can do things that and solve problems that they're just unable to do for themselves. The hospital physician and the nursing staff can't easily and efficiently grow food and get it delivered to their patients. But us collaborating together, we can kind of find solutions for the local food system.
It sounds like this community partnership has really fostered a sense of provider satisfaction, as well as addressing a real need there in the community. Tell us, Lena, are there other favorable health equity outcomes that you've seen from this collaboration?
Once we're working together with community, we can explore multiple challenges because the impact of structural racism that closes off opportunity to our residents. The family that is food insecure is the same family that has limited access to employment, transportation, and housing. And for those families in this community, it's all one big problem. It's not these different areas. How do you prioritize my need for food or my need for medicine? My need for safe housing versus my need for employment? It's impossible to prioritize those things. So in partnership, our coalition actually links food justice with economic justice. And so for the resources that we bring in and this food distribution program, we are changing the local food system to not only distribute but grow on our own urban farm, train our youth in the high school so that their skills in urban agriculture. We've had 2 students go on to college for food science and come back to the community being food advocates. And this is a social enterprise. So when we think about the lack of food, the disruption in the local food system, the way to rebuild that for sustainability is to create a local food system so that residents can be food entrepreneurs, they can be the growers, and they can be the deliverers. And over the last 5 years, we've been able to expand and build that up. And we're really proud of the successes that we've had and our vision. And I want the hospitals hearing this podcast to know that there are other community coalitions in their neighborhood that are working and mobilizing in this way. These hospitals are able to partner with these community coalitions that can create opportunities to leverage and advance health and well-being in unique ways. A hospital doesn't only play the role of a healthcare provider. Sometimes a hospital in a community is the largest employer, or they can be an anchor institution to promote affordable housing.
Thank you for that, Lena. In closing, I just want to say I'm inspired to see how a program to advance health equity continues in the face of this huge health crisis. We know that vulnerable populations and minority communities are being adversely impacted by the virus. Lena, what's your best guesses about what we might learn or what we might see from a public health ethics or a health equity perspective when we're on the other side of this pandemic?
Thanks so much for your question, Darren. And from a theoretical standpoint and the history of public health ethics, I used to teach and discuss that policy change comes not because as a society we're willing, but it actually changes because of brute force. And our response to COVID is going to force our public health systems to change. From an asset perspective, we can see that policies, systems, and environments around public health will be forced to change because of COVID. Our strategies of how hospitals relate and partner with community will be forced to change for the better. Our hospital systems and our community coalitions are seeing opportunities to leverage and work together. There's not enough nurses and staff to do community outreach, but residents can be mobilized as health leaders to mobilize for well-being, such as the example that Proviso Partners is doing to create a community wellness hub that will be led by residents supporting each other as peers. This is cost-effective, this is culturally effective, and it can alleviate the burden on all parties. And that's looking at this as what could change for the better. The pandemic is causing us to see the broken chasms within our healthcare system. As a public health ethics advocate, these needs of food access, housing, transportation, and health and economic systems to correct for those challenges has been the battle cry for 20 or more years. And instead of things getting better over time, things have gotten worse, particularly for low-income African-American communities. And so this response and the pandemic is making everyone aware, not just public health advocates and not just the communities that have been suffering, but for all of us to see where the systems of public health and clinical health are not working for us as a society. And it shows us that we're all in this together. Nobody could have imagined that our whole culture would be at a standstill, and that we would not be able to mobilize nationally, regionally, and locally to respond effectively. We in Proviso are hopeful that Chicago will not go through what New York has gone through, that we would have learned and change our habits and our ability to collaborate to protect each other. We hope that social distancing will change the trajectory. We have to recognize that this isn't change because of willingness. It's being changed by force. And just like the HIV transformed public health, COVID is going to transform public health, the field, and the whole field of public health ethics in good ways, and hopefully our ability to create equitable solutions that actually start to dismantle structural racism in a way that we've never seen before in American society.
Indeed, as you said, we are all in this together. Lena, thank you so very much for your time today and for sharing with us this very inspiring and important partnership between healthcare providers and Proviso Partners for Health, an organization where people are not only served, but are co-creators in building a more just and equitable model for healthcare delivery and services. You are showing us that even in a pandemic, together we can still build structures to advance health equity. We will post this and links of resources identified here on our webpage, ifdhe.aha.org, and many other COVID-19 related resources are available at aha.org. And everyone, please take extra good care.